Okay. So thanks again. Just wanted to, is it the full screen, David?
Yes, it's perfect. We're seeing it perfectly.
Okay, great. So I want to just give folks a little perspective if you haven't thought about TDH in a while, and just remind folks that TDH, we're considered a mixed model state. So we have our Tennessee Department of Health regions, those kind of multi-county areas. The blue, for example, is West Tennessee region. They are us, we are them. There are 89 of those counties. And then we also work closely with our city-county colleagues, Memphis Shelby County Health Department, the Nashville-Davidson County Health Department. There are 6 of those. So 95 counties, and we have health departments in all 95. So just wanted to level set on that. In terms of the division that I work in, I direct the Communicable and Environmental Diseases and Emergency Preparedness Division. And as David said, I'm a state epidemiologist. We have a really broad portfolio of programs, and you can see amongst those is the HIV STI program. Then we also have some kind of helpful programs that are cross-cutting, and the one I'll just highlight there in particular is the Surveillance Systems and Informatics Group that help us collect really important information electronically about case reports, about CD4 counts, a whole range of different information that they help the programs with. So that's just a high-level overview. I want you to take a look at this pictorial org chart, and because there's some faces on there, I want you to, some of them are younger than they appear younger than they actually are now, myself included. But Dr. Ralph Alvarado is our commissioner. He's a clinician, has worked in private practice. He was in Kentucky. He's been with us about 15, almost a year and a half, about 18 months. So he's made a lot of visits to different partners around the state, and I'm sure would love to learn more about CFAR. Many of you probably know Tim Jones. Tim was the former state epidemiologist and now the CMO for the state. Tim and I both have been involved with EIP work and closely connected to Vanderbilt over the years. And of course, Tim's wife, Jill, is also a physician at Vanderbilt. Some of you may know. I kind of have a long history with Vanderbilt as well. My father practiced gastroenterology at Vanderbilt and the VA for about 40 years.
Is your father Dewey Dunn?
It is Dewey Dunn, yes.
Oh my God! Oh my God!
Yeah. So,
yeah, I did not know that. Oh my God! Dewey's an icon. Well, it was an icon. Oh my God!
So another face that I want you to be sure.
And I was the chief resident of the VA.
Okay.
So I had a lot of interactions with Dewey.
Excellent. He's doing well. He's 88, doing well. Mary Margaret Phil is my deputy, and Mary Margaret trained at Vanderbilt, and is also adjunct faculty, clinical faculty there. Very important person in our program. And then I want you to, on the right-hand side, go down to Rand Carpenter. Rand is a veterinarian by training like myself. Rand went to undergrad at Vanderbilt, and then has worked in a variety of public health roles, both domestically and internationally, worked in Haiti, worked in Kenya on various public health programs, and is serving in a programmatic role with the HIV, STI, viral hepatitis group. I've got another picture for you that just to further imprint on these important people for CFAR and the relationship with Vanderbilt. You see Rand there in the checkered shirt, Dr. Carpenter is the program director, and of course Dr. Nash is our HIV director, and we've talked about his history with Vanderbilt training and being a clinician. He's currently a clinician with us as well, and sees patients in clinic for TDH. Great addition. And then our newest addition is Dr. Christine Thomas, who is in a medical consultant role. She's an ID physician, completed her CDC Epidemic Intelligence Service training with us over the last 2 years, and working closely with Bill Schaffner and myself. We're excited to have her to work closely with our other SMEs in those programmatic areas. So as I was,
Christine just joined the call, by the way.
oh, awesome. Well, there's your picture, Christine. Um, as I was getting ready for this, David, I went down to what I kind of consider our archive, which is just basically a file cabinet, and I was looking back for the first kind of bulletin or information that we had about the emergence of HIV. And I came across this bulletin. It was the first thing I could find, October of 1981. And you see the title there, Kaposi sarcoma and pneumocystis pneumonia, a new disease presentation, question mark. So just interesting to think about the history in TDH. That little summary report, those used to be mailed out to providers across the state. Goes on to say, we urge physicians to participate in a nationwide survey being conducted by CDC. So I think, still to this day, we're interested in the research and understanding how to understand HIV, AIDS, and prevent it, even going back to October of 1981. The other thing that I found interesting, I was looking at our morbidity reports and trying to look, like, where's the first time that we document or present numbers in tabular data, and it was in our 1984 morbidity statistics. And glad to share these slides, as I mentioned, but you kind of go down to the last paragraph, and it mentions the 3 cases reported in 1982, 4 in 1983, 21 cases in 1984, and the cumulative mortality, the last sentence in that paragraph, 12 deaths or 43% case fatality rate. So, at that time, 1984, I was going to high school at Hillsborough High School, just down Hillsborough Road. And remember those times and the uncertainty and the things that were in the news at the time, and that those mortality statistics and what was occurring, I think was, very concerning, obviously, to everyone at the population level. I feel, just indulge me, I'll share just a personal anecdote also. When I went to college, I went to Baton Rouge to LSU, and that was in 1987. My uncle, Carl, and that's a picture of my brother's wedding. Actually, David, that's my dad on the drum set, Dewey Dunn. Maybe a little out of character for some folks that know him, but he's a drummer. But my Uncle Carl, who's standing talking to me, I have a lot of hair on my head at that time that I don't have anymore. But Uncle Carl was a gay man, and when I moved to Baton Rouge, he lived in Baton Rouge, and got to know, got to see his health decline as he was infected with HIV, and was at his bedside September 27th, 1991, when he passed away at Our Lady of the Lake Hospital in Baton Rouge. So I just want to share that kind of personal anecdote as well, that that time frame and the emergence of HIV really resonates with me at that time in my life too. I'd say, in addition, kind of at the population level, we continue to see morbidity. So I think the work that's being done in this partnership with Meharry and Vanderbilt, Nashville Cares, and TDH just still remains very important, because we continue to see morbidity, about 20,000 cases that we estimated in 2022 of persons living with HIV in Tennessee. And then there are unexpected challenges as well that we need to be able to continue to face. And we would not have predicted that the clade of monkeypox that emerged in Europe and entered the U.S. would have the effect that it had on the gay bisexual population. But some really dramatic cases and mortality associated with people that are out of care living with HIV. So we still face challenges, and even in some of the recent modeling from CDC predicting if if the other clade of monkeypox emerged in the U.S., they predict that Memphis would be potentially heavily impacted. So concerns within our state. So this is my last slide, and I'll just say that the partnerships are really important to us at the Tennessee Department of Health with CFAR, with our community-based organizations, with our federal partners and funders, CDC and HRSA. And of course, HRSA funds the Ryan White program, and many of you might have seen when Nashville Cure sponsored Ryan White's mother to come speak about a year and a half ago for World AIDS Day. And then our metro and regional health departments as well are just really key partners. So I just wanted to give that kind of perspective, let you guys see some faces and names that you may not have put together before. And then I'm going to pass the baton to Bill. And Bill, I can advance your slides. And David, you just let me know if you want to pause or have questions or anything like that.
Let's take a second. That was wonderful, John. Any comments? Just for a few minutes, we want to make sure that we save enough time for Bill and Rob. If not, we can keep moving. And we'll probably have time at the end. So, Bill, the floor is yours. Bill, you're muted. You are muted.
Shucks, there we go. Yeah, these are elementary things we need to pay attention to, recording and muting or unmuting. So John and Rob are going to do the play-by-play. I was asked to give a little color commentary here, trying to recall a couple of episodes early on in AIDS, one of which in particular involved a strong Vanderbilt Tennessee Department of Health collaboration. I thought of two episodes, one with very personal consequences and one with broader national consequences. Next slide, please, John. So the first episode occurred in the early 1980s. The first case of AIDS diagnosed in Nashville was at the old Nashville General Hospital, depicted below, and the clinician making the diagnosis was Dr. Barney Graham. And for those of you who are not familiar with Barney, let me just do a little side tangent here. Barney did his clinical training as a resident and a fellow here at Vanderbilt, and then joined the faculty and got also a PhD in basic virology. He went from here to the NIH, where he and his team, working on initially RSV infections, figured out a way to stabilize the pre-fusion protein of RSV, which enabled the entire development of RSV vaccines. And he also and his team played absolutely critical roles in developing COVID vaccines. So that's a strong part of the historical tradition here. I'd like you to remember Barney Graham's name. This first patient died, and permission for an autopsy was obtained. It may have been actually a coroner's case. In any event, although there were facilities at the Nashville General Hospital for performing autopsies, many autopsies had been performed there. In the next slide, it was determined by the then chair of pathology here that this was such a distinctive event that the remains were to be brought to Vanderbilt and the autopsy was going to be done here at Vanderbilt. Indeed, this was going to be a faculty-only autopsy. Mind you, most of the autopsies are done by residents with faculty supervision. But in this case, the chair designated 2 faculty members to do this autopsy, and indeed, there were to be no residents or students even viewing the postmortem examination. And as you may or may not know, there was kind of a bleacher section of seats where students and residents could look while autopsies were being performed, but they were not to be in the room. Now, as it happens, the person who was in charge of infection control at Vanderbilt at the time, c'est moi, was not informed of this and could not communicate to the autopsy personnel the CDC recommendations for personal protective equipment that could be utilized. And in the next slide, as you can imagine, in these stressful circumstances, 2 injuries were sustained during the autopsy. The male faculty member had a splash of body fluid in the eye. That's one that infection control could have protected against with the recommendation to use eye protection during these kinds of procedures. The female faculty member, I thought about this some more, did not sustain a needle stick injury, but rather a scalpel stick injury that occurred whilst doing the postmortem examination. It was my role to link with these people. There were no therapies available at the time. What there was watchful waiting. You waited 6 months and did a serologic test to see whether you had seroconverted and developed HIV infection. I knew the male faculty member very well. We were buddies. Our friendship increased during that time as I counseled and empathized and expressed sympathy and supported him. I, of course, had been acquainted with the female faculty member, but during this time, we became better acquainted as we had several conferences together in support and talking about the futures. In the next slide, neither seroconverted after 6 months. So that was an hurrah. But apropos of the female faculty member, pre-exposure, I learned as I had become better acquainted with this person, we became friends and she shared more personal information. Pre-exposure, she and her husband were trying to have another child. Post-exposure, time had elapsed, these events had occurred, and they had conferred and decided not to have another child. This was early in AIDS for us in Nashville, but it was a profound lesson for me that these exposures have deeply personal consequences, even for people who do not seroconvert. They can have, in many cases, as it had for this faculty member and her husband, a life-changing kind of event that had occurred. This lesson helped me greatly as I counseled many others who had, over the years, exposures to HIV in the course of their professional work. So that was the first episode, which had, for an individual and for me, personal resonance. Then there was the second episode. This occurred in the late 1980s, about 1988. Let me set the scene. AIDS was well recognized. It had no treatment at the present time. We could make diagnoses, but treatment was not yet available. In essence, it was a death sentence for most of those infected, so it was still feared and enormously stigmatized. In that context, there was a national debate going on about whether dentists and surgeons with HIV/AIDS should be tested. Should there be a regular testing program annually, semi-annually, quarterly? All of this was being discussed to detect surgeons and dentists and other interventionists, but particularly surgeons and dentists, as to whether they might have HIV infection with the consequent concern that they might transmit this infection during the course of their professional work to their patients. This was an intense discussion ongoing. I would also say that all AIDS patients were reported to the Tennessee Department of Health and to state health departments across the country, but nonetheless, all the details of their public health investigations, and their names were held in great confidence. And this was rigorous and was part of the DNA of the entire public health community. And then in Nashville in 1989, the Nashville media reported that a local surgeon had AIDS. And this was as a consequence of that surgeon's family being very forthcoming, speaking to reporters. And suddenly, as you will see in the next slide, there was no confidentiality. This is the front page of the Nashville Banner, our long ago afternoon newspaper. Front page, Nashville surgeon infected with AIDS. There's his picture and his name and a long discussion. This also appeared in the Tennessean and in what was then the 3 local TV networks, 2, 4, and 5. And not just on one day, but this was a story that went on for several days and indeed weeks as various aspects came forward. That being the case, since there was no confidentiality, that opened up an opportunity for a more intense investigation than might otherwise have been the case. This is where the Tennessee Department of Health became involved. The EIS officer, the Epidemic Intelligence Service officer at the time, was Dr. Ban Mishu, now Dr. Ban Alos. And she then, as a consequence, led the nation's first look-back investigation. It was an extraordinarily tense time, but Nashville was a special community. The chief administrators of the hospital where this surgeon worked, not Vanderbilt, reached out to me because I had a certain standing in the community and actually asked me to help investigate the consequences and the implications for that hospital and the hospital's patients. I was co-mentoring Dr. Mishu, Dr. Alice, at that time, and we were just thinking about how it is we could get access to that institution and collaborate with them to do a public health investigation. And with that invitation to me, the door opened.
Bill, I should mention that a lot of people don't know that Ben Allos is one of our current infectious disease faculty members, been with us for a long time.
I wanted to mention that, so thank you. Let me just build on that and just say she's not only a longtime respected faculty member at Vanderbilt, she's just been named co-chair of the Medical School Admissions Committee, so she has real standing. So there were 2 questions that really were very important. Was the surgeon's infection acquired intraoperatively? And second, did the surgeon transmit his infection prospectively in an ongoing way to his patients during surgery? In the next slide. So question 1, the source. Ban looked at 2,160 surgical patients of this surgeon. We went back to 1982 because we recognized that HIV infection could be active without clinical syndromes, clinical manifestations for a long time. And she looked at every one of those charts, and there was no evidence of intraoperative needle stick or scalpel injury or any other breach of rigorous intraoperative infection control practices. That made it much less likely that the surgeon had acquired his infection intraoperatively. Simultaneously, a Tennessee Department of Health field investigator who we thought had extraordinary diligence, persistence, diplomacy, and other wonderful characteristics, and was an experienced HIV investigator. We thought he was so good. He was probably the best HIV investigator in the state health department, at least east of the Mississippi. He undertook a conventional investigation, and his field investigation revealed that there was a rather, we'll call it conventional, likely mode, in fact, highly likely mode of this surgeon becoming infected. Nothing new, nothing required to implicate intraoperative transmission. Let's put that aside for a second and go on to the second question. How about transmission to patients? HIV antibody testing was offered free to the surgeon's patients. And in fact, if they were distant and wished to go to their private practitioner, the state would reimburse the costs of that testing. There were 2,160 patients of this surgeon since 1982. None of them were in the Tennessee AIDS registry. During this period of time, 264 of these patients had died. Their death certificates did not mention AIDS, and likewise, they did not appear in the Tennessee AIDS registry. That left 1896, of whom 616 availed themselves of the testing. One was found positive. That patient was a relatively young man who had a very limited surgical procedure. It was a lymph node biopsy. And looking back on his history, it was really quite clear that he was not only infected, but had AIDS at the time the lymph node biopsy was performed. And that judgment has not been challenged by anyone. As a consequence, next slide, this investigation was published in JAMA and had a go-along, very supportive editorial. Next. So to conclude, question one, was the surgeon's infection acquired from an infected patient during an operation? I think we can say no to that. Question two, did the surgeon transmit his infection to any patient during surgery? None was identified, and it was concluded that the risk was very low, if there was any risk. Last slide, please. As a consequence, should surgeons or dentists be tested regularly for HIV infection? That intense discussion that was ongoing nationally on the publication of this, the results of this investigation, that discussion just abated and hasn't been heard really since there have been subsequent investigations that have reinforced the public health policy of not requiring standard testing of all invasivists for HIV. So a wonderful collaboration between Vanderbilt and TDH and really the CDC, and it led to a major public policy decision, or shall we say non-decision. Thank you.
Bill, that was absolutely wonderful. Thank you. And in the interest of time, we should hand off to Rob and then loop back around if we have time at the end.
All right. I'm going to do my best to follow Dr. Schaffner's presentation here, and I'm going to share my screen. Get slides going here real quickly. Okay. And would like to thank Dr. Haas for the opportunity to present information and be part of this conversation this afternoon. And I'm going to do two things this afternoon. The first is I'm going to start with some data that we prepare annually to kind of give you a snapshot of the state of the state. And then I'm going to highlight a collaboration between the CFAR and several other entities, including TDH, that I'm very proud of, that's yielding actionable results on the ground. So we're going to start with sharing two different online resources. And I want to also thank Riley Gulbrunson, who's on the call. Riley is one of the epidemiologists in our HIV surveillance and epi team, led by Rob Garman, who prepares this data for us. So you can see two images on this slide. On the left, you have the Tennessee HIV epidemiological profile, which is published annually. And in the slides you're going to see in just a minute, we'll look at some data from that. The URL is below that. That's published every year and is publicly available. Another data product that we're really proud of is our HIV data dashboard. And what you can see across the top of the screen there under the part of the graphic that says Tennessee HIV data is just a snapshot from one piece of the HIV data dashboard, and you can see the URL beneath that. That's also publicly available data that's updated annually and is driven by Tableau. So you can go in and look at different regions, you can look at different demographics, and you can see all sorts of fabulous data that Riley and Rob Garment and their colleagues produce for us every year. So I want to dive into it and focus on one particular data point over the next few minutes. This is a
Hey, Rob.
Yeah.
We're seeing the presenter mode. If you wanted to, you could switch with the display settings button, and it would allow the audience to see the presentation mode.
There you go. Okay. Thank you, John. That's all.
Yeah.
Okay. Thank you. That's much less distracting. All right. Also allows me to hold my punchlines. Okay. So here is the continuum of care for HIV in Tennessee as of the end of 2021. There were at that point in time about 18,000 and not quite 19,000 people living with HIV in Tennessee. The number is over, I think, 21,000 now, by 18,695 at the end of 2021. And you're going to see a theme that we continue here over the course of the presentation. About 62% of those people managed to be linked to care in 30 days. And that linkage to care in 30 days is a standard of care. So we would all like to see that at 95% and not 62%. We see 80% of the total population receive any care. And the way we measure care is we use labs as a proxy for clinical visits. So 80% of the people who are linked to care, 80% of the people who are diagnosed receive an initial lab. And received any care basically covers the first lab visit where a person gets their initial viral load and CD4 cell count, meets with their clinician for the first time. The next column is retention in care, which is measured by two sets of labs, 3 months apart in a 12-month period. And you can see how drastically the difference is between people who get a first set of labs done and people who get at least two sets of labs done in a year. And overall for the state of Tennessee at the end of 2021, our viral suppression rate was 68%. That's for all 18,695 patients. What I'm particularly proud of, and what this slide shows, is that people living with HIV, Tennesseans living with HIV, who are enrolled in the Ryan White Part B program that we run at TDH, have better healthcare outcomes across the board than those who are not enrolled in our program. And that's a little bit on the ironic side, because in order to be enrolled in the Ryan White program, you have to be at 400% of the poverty level or lower. So we're not looking at a high income group. We're not looking at a group with a lot of means and mobility, yet we are looking at a group that has better outcomes than those who have access to private clinics, private physicians, and all the other healthcare resources that may be available to people on their own. So you can see, we'll go right across the slide to viral suppression. The state overall was at 68% viral suppression, but in our clinics, we were at almost 80%, at 79% viral suppression. And I'm very proud to have been a member of the CCC at Vanderbilt for 11 years. And we were, I think, at 89% when I left. And I understand that the CCC has crested over 90% now. So that's a signal accomplishment that we should all be very proud of. But looking across here, you can see when you compare the yellow bars to the gray bars, how much better people in the Ryan White program do. And this is a slide looking at how quickly people in the Ryan White program relative to others are engaged in care. And so if you start on the left-hand side, you can see Ryan White does a little bit better than everybody else at getting people linked to care in 30 days, 68% versus 62%. At the 90-day mark, we've got 89% engaged in care. At the 6-month mark, we've got 95% engaged in care. And at the 1-year mark, we've got 98% engaged in care. We would all like to see that 98% moved from the far right to the far left and be representative of what's happening at 30 days here in Tennessee. We have several challenges, but again, the program does a really good job meeting the needs of the 10,000 people we serve. And I should have said that at the beginning. Of the 18,695 patients in 2021, approximately 50% of those were served by the Ryan White program. We currently have just a little bit shy of 10,000 clients in the program that we serve. Now, this is a very busy slide, lots of colors, and I'm not going to walk you through all of it, but what I do want to call your attention to, and the reason I put all of these on one screen, is I want you to see what happens through the process of people getting a diagnosis, which is the upper left-hand corner, figure 57, and length of care in 30 days. So we're averaging, the black line you can see is for all populations, 61, 66, 62% engaged in care within 30 days. And people who get at least one set of labs, that's 80%, and that's great. But what is an ongoing challenge for us across the state is the significant difference between figure 58 and figure 59 at the bottom of your screen, where you can see 80% of the population gets an initial set of labs to make the diagnosis, but only 57% of the population remain in care. That's a significant challenge for us. We're very lucky in Tennessee to have what are called HIV Centers of Excellence. Our Center of Excellence program is comprised right now of 16 clinics. The Vanderbilt CCC is one of those, as is the Vanderbilt Pediatric HIV program. And those sites agree to undergo an annual audit and perform at a higher level of care and do more comprehensive care than just simply tending to a person's HIV status. And about 70% of our 10,000 clients have access to one of those centers of excellence. And I should also note that my former mentor at the CCC, Dr. Stephen Rafanti, was the one who wrote what became the legislation which enacted the Center of Excellence program into law. And it's actually in the TCA that we have this program. So we're very proud of that. And one of countless contributions that Dr. Rafanti's made to the well-being of Tennesseans living with HIV over the years. So we do face a challenge. Again, about 30% of the 10,000 we take care of do not have access to one of these centers of excellence because they're mainly located in urban areas. We're very proud at TDH that of the 16, 4 happen to be located in rural county health departments. There's one in Robertson County where I serve 1 day a week. There's one in Putnam County in Cookeville. There's one in Columbia and Murray County, and then the West Tennessee Regional Health Office in Jackson, Tennessee. But those are all centers of excellence clinics, and the rest are big sites. SIMPA in Southeast Tennessee, Positively Living in East Tennessee, ETSU, Regional 1, Vanderbilt, and sites like that. So you can imagine, if you can imagine a picture of the state of Tennessee, we are a largely rural state, and there are whole vast areas where there are not sufficient clinical resources to meet the needs of people, assuming that they have to go to a physical space to get care. So we're looking at other options for that. And one project that I want to take a minute and highlight that shows the work that is being done and the results that are being achieved on the ground is this Project Connection. And Project Connection is led by Drs. Pettit, Audette, and Ribeiro at Vanderbilt, Dr. Latrice Pichon at the University of Memphis, and then I am the primary TDH representative for this project. And in addition to this group of academic collaborators, we also have 5 partner sites in Shelby County: St. Jude Children's Hospital, Regional 1, Adult Special Care, Christ Community, Shelby County Health Department, and Le Bonheur Children's Hospital. And so what are all these folks doing? Well, what all these folks are doing, thanks to the leadership of Drs. Pettit, Audette, and Ribeiro, is they are building out a comprehensive Rapid Art Start program for Shelby County. And why is this important? Well, it's important because Memphis ranks #2 in the country for HIV incidence. And linkage to care within 30 days is a well-known and long-established priority for a variety of programs, including ending the epidemic. And in spite of that, you can see by the bar chart on the left of your screen, the U.S. goal is 90% be linked to care in 30 days. And Memphis, relative to other similarly sized cities, is struggling right now. They're at 60%. So real clear priority, as Dr. Haas said earlier, it applies to a variety of settings, not only academia. We all tend to be siloed. And even though we all may tend to be working on the same population, we don't always do a good job of communicating our strategies and tactics and coordinating those on the ground. So that's the work that Dr. Pettit and her team, Dr. Pashan in Memphis, are leading. And they have convened multiple meetings with CDC, with our partner sites in Memphis. Here's some of the performance measures that they're looking at across all these sites to ensure that when a person shows up and has a positive HIV test, that they're offered rapid ART on the spot. And also very grateful to a strong partnership with Gilead, who is providing the samples of Biktarvy that allow this to happen. So I'm not going to walk through all these performance measures, but I just want to make you aware it's a very robust program. And I thought I would quickly share some of the demographics of what HIV looks like, new diagnoses look like in Shelby County across 4 separate sites. You can see a little bit of variation in percentage male across the 4 sites. When I initially looked at this data, I was struck by the median age, 18, 15, 23, and 13, significantly Black. And transmission factor is, as you might expect, either MSM, and sometimes we have high unknowns depending on the site. But very concerned, again, to highlight the young age of this population, and reflecting back on the data I showed a few minutes ago, the fact that it's difficult to keep people engaged in care. Even though they may touch a clinic once, we have to do a better job of keeping them in care. So those are a few data points, and I would encourage everyone to grab those URLs and go online and check and see what TDH has to offer. So thank you all very much for your time.